and you
Recording started.
So mute your phone unless you have a question, and then you can, click back in. And thank you.
Yeah, and anybody that's got questions, feel free to ask as we go along. Don't wait till the end. I mean, if something pops up or pops in mind, ask away. Ask anything. We've had a lot of good questions in these sessions. We've discovered a few things that we weren't ready for. That'll help us out. We can prepare for when we go live. So, my name's Todd Myers. I'm Crown Health out of St. Louis, and I will be there along with Leah in about 2.5 weeks. We will be on site there to bring Riverside online with the eMAR application, and that's what we're going to look at today. So today's going to be a very high-level session. I just want to go through some of the core functionality of the eMAR, show you guys some of the basic uses, some of the more popular uses and functionality, some of the buttons. We won't get down into the weeds. I'll try to keep it high-level. Like I said, ask questions as we go. If it's already been asked, we'll definitely get you an answer. If not, we'll get back to you. But there's ask anything. So we want to make sure that this is configured for the workflow at your facility. So if something that stands out, let me know. I'm going to start with the buttons across the top here. We're logged in right now, and what you see when you log in is this window every time. So no matter if you're an administrator, you're a provider, you're an MHM nurse, you're a Horizon nurse, it doesn't matter. When you log in, this is what you will see, this window. So you'll be very familiar with this window, after a couple shifts in the eMAR. But across the top, we have a ribbon of buttons. And we primarily use these three on the far left. These are the most commonly used buttons. There are some others we'll get into when we do live training, but right now today I just want to stay with the basic stuff. Obviously the red X, that's an easy one. Click the red X, that'll log you out of the application. Same thing as clicking the red X in the upper right-hand corner. If you're going to walk away from the computer, you guys use an ECW today, so you don't want to leave computer screen up, you don't leave patient information screen, you want to log out or close the screen before you leave or you go to another area. So an eMAR is the same way. Red X in the upper right, red X in the upper left gets you to the same place. The next one is this blue arrow. In the system, it's called a back button. It's really a clear button. It clears a patient profile. So if you are looking up patients and you want to go look up another patient, or you want to look up a set of patients, maybe a certain unit or a certain facility, you want to use this back button to clear. That clears whatever record you currently have selected. And then the third one, of course, is a refresh button. It's not lit up right now. When I look up a patient, that will light up green. And that allows you to refresh the meds that are on your screen. It'll push any meds that are no longer due down to the bottom of the MAR. It'll make sure all the meds that are currently due are pushed to the top of the MAR. It makes it easier to look at. So if you're working through a MAR, you've got a lot of meds, maybe you lose your place. If you refresh the screen, it'll kind of sort everything for you automatically, and you can begin working again. And I'm not going to go into the other buttons just because they're not that widely used. Across the top, underneath our ribbon of buttons, we have our demographic information. So name, date of birth, location, ID number. You can look up a patient two ways. You can look them up by name, last name, comma, first, or you can look them up by ID number. My recommendation is to look them up by ID number because that's very specific to that patient. If you look up someone by name, you're not looking at a single facility, you're looking at all of PDP. So if I go last name and I type in Smith, I'll tell you what I mean. I'm going to get a long list of all the patients in PDP with the last name Smith, and I have to go rolling through here and find my patient. So I would use that as a last resort to look someone up by name. I would always go by ID number. So what I'm going to do is over here to the right, the system always starts in the ID field. That's where the cursor begins. I'll type in my ID number. This is test patient in the system. So when I type in an ID number and hit enter on the keyboard, I can pull up the patient. Now, after we go live at Riverside, in the very near future, we will be scanning wristbands to pull up patients. It won't happen during Riverside. I know this is an initiative at PDP, something that they're working on, something we've worked in conjunction with the group over there. There's a timeline of when that will be live. I just know it won't happen, by March when we're out there. When we get to that point, you don't have to type in anything. You don't even have to touch the keyboard or the mouse. You will be scanning the barcode on the wristband. It'll automatically pull up the patient on the profile. When the next patient comes to the window, you scan the next wristband. It'll pull up the next patient. You don't have to click the back arrow up here or click anything. You just scan wristbands, and it'll continue to pull up patient profiles. So underneath my ribbon button at the top, now that I've pulled up a patient, demographic information is filled in. We display our patient's last name first. My patient's name is patient test. date of birth is here to the right, their age, their co-location, and then their PCU would be like C1, Pod 3, Cell 26, Bed 1, whatever we're getting from PDP. The eMAR is tied to Lock and Track. So when Lock and Track gets an update on patient movement, be it intra-facility, if they're going pod to pod or pod to seg, or seg to infirmary, wherever it may be, we get that information every 50 minutes in the eMAR. They go to another facility, we get that update. If they are discharged, again, we get the update. So all admits, discharges, transfers, that's all automatically updated in eMAR coming from Lock and Track. So you guys don't have to mess with that. It's all automatic. Out to the right, in ID number, of course we know that. That's our identifier that comes from Lock and Track. We'll use that originally to look up patients until we get the wristbands in place where we can scan out patient ID numbers. Underneath our demographic information, we have a few extra fields. So we have allergies. My patient right now doesn't have any allergies, but allergies will be coming from ECW. So ECW is your health record, that's your source record. We want all allergies to be entered in that system. We're actually going to turn off allergy entry within the eMAR because they won't get communicated back to ECW. We don't want them to get out of sync. So the eMAR will just display the allergies that are on the profile that have been received from ECW. That's a problem field underneath. We're not going to use that. You guys have diagnosis and problem already in ECW. That's all listed out with ICD-10 codes. We don't want to list that in eMAR. Again, ECW is the source record, so that information will be contained in the EHR. Underneath diagnosis problem, we have notes. So every place, every site I've ever visited, and I see paper MARs, I find post-it notes. And post-it notes are used, staff to communicate to staff, a reminder, an indication of some sort around that patient's MAR, and that's what this notes field is here. When you click on notes, we have a list of built-in notes, that we've used for other clients. We can adjust these or add to these if you feel there's something that's heavily used. We can pre-configure a note so you don't have to come down in free text. But if you come in here and check one, let's say we want to crush meds and they've got a history of cheeking, I come in and click OK. Now that's been added to the notes field. Down the road, if they get better about taking meds, I can come in here and I can take them off. I can come out here and take these out. I've also got a note down here that patient refuses insulin. I can delete that. Click OK, it clears up. Now my notes field is empty. I can go back in. I can type a free text. I can type in a new note. Oop. And that's part of the patient profile. My advice on that is keep those notes, relative to the patient record. It is part of the record. We want it to be medically related. Just keep it, keep it professional. Keep that stuff, that's on the MAR that anybody could look up. Anybody's going to be able to see that when they log in. That's the notes field. Underneath notes, we have our tabs. So the MAR tab you can see is highlighted right now. That's the active tab that we're on. The patient tab won't be used. There's nothing on the patient tab that you can't gain from up here at the top in the demographics area. The worksheet tab we're going to hide, so that one's going to go away. The order tab, this is a history of all the orders that have come from ECW. This tab will be view only. Again, ECW is the record for all orders, so you won't be able to enter orders in here. It's all coming from ECW. It's a one-way street. Privations, we won't spend a whole lot of time on this today. This is more for our providers, but we can record observation around blood pressure checks, around blood sugars, insulin doses. You can see some graphing over here. Again, this is a test patient, so I don't have a ton of data. Observations tab. And then I've got a reports tab. And we'll talk about reports last, if we want to look at administration compliance, or we need to print a MAR, keep on person activity. That's all out here under that reports tab. Back to my MAR. You guys will be spending most of your time. Anybody administering meds, you're going to be hanging out on the MAR tab all day. This is where all the action takes place. So underneath tabs, I've a series of radio buttons out here that have some color to them, and right now all is selected. So obviously all is all medications. If I click on scheduled, I'm only going to see my scheduled medications, and those are going to be pushed up to the top. PN is going to give my PRN meds. Insulin will just give me my insulin meds. So if I'm doing an insulin med pass in the morning and I'm not handing out oral medications, I can click on insulin and the system will stay on insulin no matter how many patients I look up. Every time I look up a new patient, it's going to stay on insulin and show me just the insulin meds. It filters them out. So you got to think of these as med filters. That's what they really are. So if you have KOP meds, I don't have anybody on KOP. I don't have this patient on KOP right now, but I do have them on an insulin, and I do have them on a PRN. I'm going to go back all so we can show all meds. Underneath that, I've got essentially 4 columns of information. So the first column on the far left is our drug information. So all of our drugs, drug names, it's in black and bold, brand, generic, the dose, start date, stop date, the frequencies down here. Any additional information that might come through from the pharmacy will be listed here in smaller text as well. To the right, I've got 3 columns for all the various med passes. We've got them divided into 3 shifts, morning, noon, and night. The active med pass will always be the middle column. So right now, and I'm on, well, today I got the server actually set to Eastern time. So it's 2:16 p.m. So if you notice, my new window runs from 11 a.m. to 3:15 p.m. So that's why noon is in the middle. At 4 p.m., the system will auto-update, and night will move to the middle, noon will go to the left, tomorrow morning will be out to the right. I manually move the MAR if I want to. I can click these arrows up here to advance 1 shift forward. So at 4 o'clock, this is what it'll look like. Night's in the middle, tomorrow morning on the right, this afternoon on the left. So you can always see 1 pill pass in the future, 1 pill pass in the past, and current pill pass in the middle. And again, working in the middle, notice I've got the buttons that are lit up green to be due. We'll work with those in just a moment. The buttons out here, I've got this is a 9 a.m. administration this morning. It was given at 7:46 by HCS, which is me. I'm logged in as HCS. So you can tell these are no longer due. They're a completed administration. The 6 a.m. dose was given at 9:23 by me. That was this morning's training class. Another 6 a.m. dose given at 9:17. So you can see the basic documentation of staff, timestamp, and a name. If I was logged in as it normally is me, it would say T. Myers. Todd Myers, just first initial, last name. So all of our nursing staff, that's how we'll document when you administer a med. We will be administering meds using a barcode scanner. So when we go live at Riverside, if we have a med card with patient's name on it, we scan that med to administer it. You don't have to touch the mouse, the keyboard, nothing else. When you scan a med, that's a positive administration. All you have to do is scan the med card, pop it out of the card, administer to the patient, and you're done. You've got 5 meds, scan all 5 of them. Pop out all 5, hand out all 5. We will replicate that in live training the week of the 19th. So you will have barcode scanners, you will have badges, you will have med cards with barcodes on them. Most of your administration should be done through the barcode scanner. You shouldn't have to grab a mouse or a keyboard. When you scan a med card, it checks right patient, right medication, right dose, right time of day, and immediately administers the med if all of that is good. It's a split second. And once that happens, it immediately timestamps it, puts your name next to it, and done. What I'll show you today, since we're in a little bit of training, I want to show you the manual way to administer meds. For anything that doesn't have a patient name, floor stock, or quick stock as you may call it, we have to manually administer those meds by clicking on the button to administer those. So if I had a Tylenol that was coming out of a bottle or coming out of a floor stock or clinic stock card, I couldn't scan that. What I can do is I can click it. So I'm going to start with my 11 o'clock. I'm going to administer this med manually. I'm going to click on the 11. This window I'm going to walk through real quick. You'll see this a lot, but I want to show everybody what's going on in this window. The scheduled time for this med was 11 a.m. this morning. My chart time is right now. I just clicked chart this med, so it's at 14:19 or 2:19 p.m. My admin time, same thing, 14:31. It's complete. I have comments. I'm just going to click OK. It's been documented. 14:19 HCS. That's me, all done. Nothing, different, nothing strange. That's a regular administration. Now, this 11 o'clock dose, let's say it was given closer to 11. Maybe it was given at 11:15. I was stuck in lockdown. I'm just getting back to the MAR. Anything could have happened. I want to change this. I can click on my 11 again and cancel it. Just going to go back to cancel. I can go back again and click on the 11. I can change my time. I can go in here and say, you know what, this was given at 11:15. It's sweet. Now, you might want to throw a comment in here. I don't know if you guys use comments on the back of the MAR, but if you make an odd administration or if you change something, I would make a comment. I would say, stuck in lockdown. to let administration know if they come back and do chart reviews or do an audit, why was it changed? Why was it canceled and changed? Here's why, because actually we gave it at 11:15, I was stuck in lockdown, I can click OK. We'll do that. Same now, my admin time is 11:15, still documented by me, but an I out here, an I stands for information. It means there's information attached to this administration. So I'm going to click on the I. Here's my information, stuck in lockdown. Also, down at the bottom, I have a transaction log. So originally, I came in, I documented it complete, but then I canceled it. That was this morning's class. I documented it complete again, canceled it, document complete again. I changed some times in there. So the transaction log tracks everything that is done with this administration. So if nurse behind another nurse changes something, we're going to track all of that. Nothing in the eMAR is written in stone. You can always go back, you can update, you can change, but again, all of that is written to the transaction log. There's always a historical view of what happened with an administration or with an order. Let's say I'm getting ready to pop out meds, and I have a patient who's going to refuse them. Maybe they don't want their guafenicin. So I do here 1400. I can't scan it. If I scan a med, I'm giving the med. So I need to refuse it. I'm going to click on my 1400. I'm going to manually, it's not going to be complete, it's not administered, and first option is inmate refused. You see I've got other options in here for why something might not be administered. They may be out to court, it could be NPO, no coverage needed would be for insulin. I'm going to go inmate refused. We are working to get the signature pads turned on, so in the very near future, the patients will sign off on refusals. So as opposed to signing on paper, they will sign electronically. It'll be part of this screen when you go to select inmate refuse. It will pop up and ask for a signature. They'll have to sign off on that. Right now, I'm going to click OK at the bottom manually. Now I've documented 1421 by me, not administered. Again, I've got information on this particular administration. Inmate refused. Scenario was before. I can change this. Inmate changes his mind and says, hey, you know what? Actually, I do want to take that. I've got a cold, I've got a runny nose, whatever it may be. Go ahead and give me that, the guafenicin. So I can come in here and I can cancel this. On the 1400, I can cancel it. I can back. Now marked as complete. My type of comment, changed mind. Okay. Now documented. So you see that I've documented it, I've canceled it, marked it no-show, gone back and documented it again. You can continue to change that administration until it's right. You can back in time, I can go back to yesterday and change the administration if I had to. If something happened, if you want to get the documentation right, it's all available within the system to do that. So far good?
Yes.
All right. Let's do an insulin order. I don't have one due right now, but I'm gonna administer early. This came up in the class this morning. What if I have somebody going out to court? Well, now it's 2:23. They're going out to court now, and they need to get their insulin. All right. I'm gonna come and click the 1600 here. It's gonna say, hey, this isn't due. What do you want to do? I'm gonna say, well, we're gonna administer early right now. Up, same screen everybody's seen before. Schedule time, chart time, admin time is right now. It's complete. I might type in comments going to court, whatever that may be, if that's necessary. Click OK on an insulin, I get an extra window. So I do record my blood sugar in here and my insulin dose. We will get this to match the Crick scale. I just got to get it entered in here and set up. I'm not a clinician, so I'm going to put some numbers here. I'm going to say 120 on a blood sugar, nothing on a long-acting dose, and maybe we'll give them 8 units on a sliding scale. Over here to the right, you can see the last observation. So this morning at 9:23, they were 150. We also gave them 8 units this morning. On your glucometers, if they run, I think 500 or 550 is the limit on most glucometers. So if you get a reading of high, you can come down and mark that so the provider knows that they're above the range. You can comment field down here. Well, comments are not required. It's always an option. Other than that, I'm going to click save. So you can now, I've given my insulin at 224 by me. Got that eye out there, which means there's additional information. That's just my observation. So insulin, we'll be recording insulin in the system. Blood pressure checks. We'll be recording blood pressure checks in the system. I'm going to cancel this one because we demonstrated it earlier. We put 1600. I'm going to do this one early again. Nothing different. Still here. It's complete. But when I click complete, I get my blood pressure observation. Again, I'm not a clinician. I'm going to make up some numbers here. I'm going to record it. If you got the PRN med, sometimes you can go and filter the PRNs, or you can go under all. PRN's the same way. It's not going to have a timestamp on it because it's as needed. So you just click the PRN button. You can scan a PRN. It is patient specific. I don't know, Vandalin or Tasha, if you guys have a lot of patient specific PRN, or if mostly it's floor stock. If it's floor stock, you're going to have to do it manually. Right now, the system's configured to ask for a reason. If you're handing out a med PRN, what's it for? Well, this order was written for headache. So to come in and select headache, if that's why they're at the window to get it, we're just matching up the administration. That's something we need to clear, Vandalin with you, Dr. Kalu, if you guys want us to follow that workflow where we're handing out PRNs and providing a reason, or we can turn that off. That's just how it's set up right now.
They really should be documenting the reason why they're giving it.
Okay. So with that said, we'll leave that on. Ellen, I'll send you the list of the available reasons in there. As long as that's good, that's fine. If we need to add anything to it, let us know. That's easy for us to do. We can add additional reasons in there.
Thanks.
All right, we're going to go back to all. So let's see here. I'm going to go with my Tylenol here. Let's say we get an order from the provider that this patient's going to be NPO tonight, maybe NPO after 3 o'clock. So I've got a 1500 that's due. But after that, after 6 p.m. tonight, I want to hold medications. So I can go out here, I can click on my A. These A's are action buttons. A stands for active. It's an active medication, but it's also DOT, or direct observation therapy, which means they're coming to the window to get it. If I scroll down to the bottom, see I got one down here that's a D. Stands for discontinued. So provider discontinues a med in the ECW, it's immediately transmitted to the eMAR, turns to a D, and I cannot administer that med. I'm blocked out from doing so. If I were to try to click this or scan it, get an error message, won't do it. So discontinued meds are immediately transcribed electronically onto the MAR, and you're blocked from administering that med. In the live system, this line will turn yellow because I'm in development, it won't do it, but this whole line will be yellow like the notes field. So it'll stand out just like you would highlight a MAR. It'll be yellow all the way across, and it'll have the D on it once it gets discontinued. After 24 hours, this order will fall off the MAR. It'll disappear. So it doesn't stay on the MAR, it stays there for 24 hours, falls after that. All right, I'm going to go back and do hold. So acetaminophen, here we are. Click on my A, hold, person for hold, so Dr. Hayes, NPO. I can type additional comments if necessary. When I click K, med goes on hold. And it'll stay on hold. Note if I roll the MAR forward to tomorrow morning, tomorrow noon, they're on hold, they're on hold, they're on hold. They're on hold until we take them off. Come in and say, okay, they're no longer NPO, they're back from surgery, whatever it may be. I can come in, click on my H, I can do hold, take off hold. So that global hold from beginning of when you click it until the end. We have another functionality where you can hold for a set period of time. So I can say come in and hold beginning 3/1, so I want to start this at 8:29 through Friday. Okay. My reason, let's go NPO. Okay. Notice that my 1500 open because I started it at 1800. So it give me every dose after 1800 is going to be on hold until the end of 3/2. So I'm going to scroll through here and show you. After 3/2 at noon, it goes back. And so all of these are on hold. So if we know their surgery time, if we know when they're going to be NPO, we can do that. I come back and unhold my admins. Maybe they come back early. I can take them off. try to administer a med that's on hold, it's going to stop you. It will ask you if you want to override, but if you override, you have to provide a reason. And again, documented by the nurse that would be doing that. So it can be done. It's not a hard stop, but it's a warning. It says, hey, look, this was put on hold. Here's why it was put on hold and when it was put on hold. If you want to override, you have to provide a reason to do so. Let's talk KOP. So again, all of our meds that we have listed out right now, these are all active meds, so they have the A on them. Let's say that we're going to take a med and we're going to make it keep on person. So the first thing we need to do is set the medication to be allowed keep on person. We do that by clicking the A, set our KOP expiration date. And what we're telling the system is allow this med to be keep on person through a certain date. And the system always assumes that date is the stop date of the order. Notice on my Tylenol, my stop date is 3/30. So the system immediately assumes we're going to KOP this through the life of the order. 9.9% of the time, you're never going to change this number. It'd be rare you would KOP something for a month or 2 months. You're almost always going to KOP through the life of the order. So really, will you change this? You'll just leave it alone and click OK. When you do that, we just do OK. So now we know that we're a keep on person. When we actually dispense that medication, when they come to get the actual med card and we hand it out, we can scan that med. It's going to be patient specific. We wouldn't hand out for stock. It's got to have their name on it. So we can scan that med. When we scan a med that's in KOP status, this window, KOP count. And what it's asking me to do, and I got to get them added in up here, their KOP issue is missing. We'll get that added to the drop down. So I'm just going to do a count for now. But I have to acknowledge how many tabs I'm handing out. Here's every 4 hours for 30 days. That's going to be 160 some odd tabs. Let's say it was a BID dose for 30 days. That'd be 60 tabs. So I would type in 60, hit OK. Now I've administered my KOP. Track that. Anytime you can come in real quick, you can click on Tylenol. Action log. There's a dispense tab. And I have the times that I've handed out acetaminophen. Again, I did it this morning and this afternoon. Someone asked in a previous class about spot checks. We can do spot checks. Same way, we'll come in and click on the K. We'll go to set our KOP count. I will add in a drop-down spot check. That will select spot check as the type. Give us a number. Let's say we spot check at 25. Click OK, and that'll get added into the KOP activity. Same way when I go to my dispenses, my ties here. Again, the reason will be spot check. We'll change that. Let's say that we do a spot check, and we've determined that they are not appropriately taking their medication. They're either taking way too much, they're selling it, they're not taking it at all, and we want to take them off KOP. We want to revoke their KOP privileges. Very easy. We go back to the K. We set KOP expiration date like we did before, but this time we want it to expire now. First we said, okay, KOP through 3/30. Now we're saying, you know what, KOP's over. You've lost your rights. It ends right now. So all I need to do is set the date and time to today. The easiest way to do that is type the letter T, as in today, on the keyboard. It immediately changes date and time to right now. When I click OK, it goes back to being an A. So I go on KOP and off KOP the same way, setting the KOP expiration date. That, we can scan the meds. We can scan them to issue them, scan them to return them, scan them to do a spot check. Always, anything you're doing with the KOP, you can scan.
Todd, this is Vandalyn. I have a question.
Yeah.
IOPs, when we give them out, they should be signing for them?
Yes, you're right. Thank you for mentioning that. Same approach. Yeah, thank you. So what we will do is when we do our, let me set my date again. So I'm at 3:30. So I'll do an issue like we did before. We're going to get the med card. They're going to come up. We're going to give them 60 tabs. We will add a window in here they have to sign, so it'll prompt for the signature pad. We set that before we can click OK. We'll make it mandatory. So the OK button won't light up until we get a signature. And we'll be able to click OK.
Are they going to have to do that on recounts as well?
Vandalyn, you guys tell us.
It should be when we initiate giving them their, the descriptions, they should be signing.
Okay.
Okay, thank you.
Got it. Okay. So that's KOP on and off. We've done holds. We've done beep checks, insulin. Missing anything? PRN. We've pretty much covered across the board. So before I move over to reports, can I answer any other questions? Something keeps popping in my mind, something I skipped over I think before. So it sounds like at the end of a med pass, whoever didn't show up, we need to get a list of who those people are, and we need to hand that to custody, correct?
Yeah.
So what we're going to do is I'm going to clear my page up here at the top, click my blue arrow. I'm going to pull up my patient list. So let me go to my PCU actually. Oops. Hold on. Active patients. Let's say that I am CFS. So here's my list of patients in CFC1. And we can build different groups. If you want to look at CFC1, C2, C3 at once, we can do that. We'll set all that up. But for right now, there's essentially 288 people in CFC1. We're looking at all. These are all patients, no filters. Here we have filters. Now we've got a red one for patient has admins overdue. So at the end of the med pass, essentially their admins are going to become overdue. When I click this button, it's going to filter the entire list, just giving me patients with admins overdue. When I get that, didn't have anybody really. There it is. Yeah, it should be empty. I can go down and I can print this list at the here. I can hand that to custody. What that will look like is the information that we see here. So it only has name, patient, their ID number, date of birth, that's it. No clinical information on that report whatsoever. There are other filters up here. It came up in a class before. Can we print a list of those that are on insulin? Sure, right here. Order for insulin or CVS. Everybody that's on warfarin or Coumadin, INH. And we can add to these, Vandalyn, Latasha, if there's other things that you want to monitor at a high level, let us know. We can add those in. I don't think you're going to use the non-formulary because you're doing non-formularies in ECW, so we can switch this one out for something else.
Can I ask you a question?
Yeah.
About putting injections in, like for STDs.
Yeah, we can do injections. We talked about that, I think, in a previous class as well. They were talking about a monthly injection for like a Haldol deck. It'll take injections and it'll schedule them every 4 weeks or every 28 days. It's either every 28 days or every 30 days, depending on how we configure it. But those will show up on the MAR the day that they're due.
Continue to do like the STDs. We just put them in correct RX. Instead of on this MAR.
Where do you record though that it was given?
I usually record it in the ECW.
Okay. So, Dan and Tasha, also talk about that. You guys tell us, how you want to handle that going forward.
So that's that's actually a one-time dose.
Except for ones with the syphilis, it was 3 times.
Oh, okay. We can schedule those out, like, are they weekly? Like doses time 3 weeks?
Yes.
Okay, all right.
Okay. All right, that's the patient list, so to speak, for those that need to come up and either commit or refuse the med, whatever it may be. All right, go back. Let me pull up my patient here. And I'm going to go to reports now. One thing I want to clarify in reports, we talk about this a lot, and it takes a while before it sets in. There are 2 ways to run reports. There's reports at the tab level. Remember my tabs. I'm on the MAR tab here. on the Reports tab over to the right. Reports at the tab level are only going to provide information for the patient that I have selected, one patient. Patients, not all of SEG, all of Infirmary, all of Riverside, just test patient 888-888. That's it. If I want reports for a population or group of patients, I got to go to the top, go to reports at the menu level, and then reports here. I get the same reports. If you see the window, it's the same list of reports, but now I can select lists of patients, patient sets, PCUs. We'll explain all that, but that would be like all of Riverside, all of C1, or all of C1, C2, whatever that may be, whatever that patient set you're looking for. So again, reports at tab level, it's only going to be information for one patient. The first one I'm going to talk about is administration compliance. Is we find out who's either refusing meds, no showing, whatever that may be. Are they taking meds or not? We can do that from here. You can look at, a window of time. I'm just going to look back 1 month. I got a different report format. So you can go, did they miss administrations each day in a row? Are they missing administrations in a row? I can look at total days missed or administrations missed. We've got 4 ways to look at it. I'm going to go total missed just because we're in test. I want to give you some information. I've got a detail and I've got a summary. And the detail is going to give me every single med they missed and why they missed it. A summary is going to give you just the medication and how many times they missed that medication. So I'm going to give you the detail first. Let's see. How many count? Are we going 3 or more? Total. I'm going to go with 1 because, again, I'm in test and I want to show you some information. What status are we looking for? Well, we're looking for no shows, looking for not administered. Remember, did not administer, inmate refused down here. That's my criteria for this report. So when I report, down here at the bottom, you can see my missed meds. 2-8, this was yesterday, 2 o'clock, I refused it. Patient refused it. Let's say that I'm in mental health and I don't want to see the medical meds. I'm not concerned with medical meds and what their compliance is. I just want to know about my stuff. So I can go and type in a classification. I can look at just psychotherapeutic agents, antipsychotics. You can split it down by a specific product. If I want to see, are they taking their INH? I can select just a specific product. That's my non-compliance. Daniel, Latasha, that's something we'll probably spend extra time on with you guys and some of the other admin staff. There's a lot you can do with this report. Not only can you do non-compliance, you can do the reverse and do actual compliance. So if you've ever had to do, INH counts for the health department, you can come in and the system will tell you how many administrations they've taken in a row. Getting up to that, I don't know what the number count is, I forget. But they have to take so many to be deemed clear. You can get that out of the system. All right, so after I'm in compliance, let's see about a MAR. Maybe I need to send somebody out. They're going to go out for surgery or they're going to go to the clinic. When you generate a MAR, even though you've got a date range back here with whatever, you pick whatever date, year you want, just like a paper MAR, you can only go to the first of the month to the end of the month. You can't go to the 15th of January and the 15th of February. It won't work like that. So I'm going to go to February 1st. 78th, I do want to see a 31-day MAR, a normal MAR, and view that. Here's my MAR. Now to the right, you can see I've got some administrations when we were doing some testing here, but it'll put initials out there of who administered the med or what happened with that med. H is HCS. Take that back. H is on hold. So they were on hold in some of those yesterday. UCNA is not admin. If it was me and I was signing as me, it would say TM. And on the right, it would say Todd Myers, so it'll have the name of the nursing staff that administered the med, along with their initials, and just out and send it with them, or send it, the medic or custody or whoever is taking them out outside the facility. Keep on on person. Here's the other ones that's used a fair amount. You want to look at activity. So when were they, there's a ways. You can go to the MAR. We were on the MAR and we clicked on a drug name to look at the dispenses. If you guys remember, let me go back out here. So I can go to my MAR, I can go to my Tylenol and click on Tylenol. I can go look at dispenses, and I can see every time that we hit it out or spot checked this drug in the count. But if I got a patient that's on 7 KOP meds or 5 or 4 or whatever, that's a lot of work to go through and click and look at all those. My reports tab, I can go to keep on person activity. I can look at the last month, 2-1 to 3-1, give me a report. The time it was handed out, it was recounted, or it was spot checked, or it was reclaimed. You can count, date, time. You can also check compliance. Are they picking up KOP appropriately? Are they coming too early? Are they coming too late? Are they 10 days, past the time when they should have come in to pick up a med? So you can keep an eye on them and see if they're taking the med appropriately through the activity report. So good? All right. One other one, we've got time, so I'm going to touch on observations. I know Dr. Kalu's on. We record observations and then we graph these. I don't have a lot, again, because we're in development test area here, but you come in and look at, what blood sugars have been recorded, what blood sugars have been recorded. You can graph those over time. You can see the graph down here. Again, I don't have a bunch of information, but just a little bit. And they'll give you a line graph, over a 1-month period or 2-month period, so you can trend some of your measurements that are taking place in the eMAR. What questions can I answer? We've cruised through this one pretty quick.
Are times going to always be military time?
Yes.
Other questions? We do have 15 minutes left. You guys clear, or do you need more time?
Dental's good. It was a good training, thanks.
Guys, if you come up with questions between now and when we come out there, obviously there's, we cruise through this pretty quick. As you walk away, jog it a little bit, see if things, make sense, or if you have other questions, if you can get that to the EHR team, we'll get you an answer. So we get everybody taking time ahead of time to kind of take a look at this. We're all on the same page when we go live. So look forward to seeing you guys in a few weeks, and thanks for your time this afternoon.
This is Michelle. We're going to need to at the 7th, which is next Wednesday. We're going to need to connect because we still wasn't able to get dialysis on.
Gotcha. And I think if we could do next Wednesday, as long as we don't do it in the morning. I've got that standing meeting, which messed me up yesterday. My apologies. If we do it in the afternoon, we're fine.
And see what's a good time and date for them, and then I'll get back to you.
Perfect.
Thank you, everybody.
All right. Thanks, everybody.
Thank you.
Okay. Bye.
Thanks.